Sri Lanka did not have a whole lot of digital health intervention. So, the Ministry of Health, we provide healthcare for our citizens free of charge at the point of delivery. There are 22 million people in the country, and we have a network of around 1,100 healthcare institutions under the Ministry of Health. And we provide primary healthcare, secondary and tertiary healthcare, public health services, meaning preventive healthcare, and other services through this network. And annually, we cater about 55 million OPD visits and about 9 million in-mode care episodes through this platform. And if you look at Sri Lanka's indicators, we are doing quite well with especially in the maternal and child health area, and we have very high uh, life expectancy at birth for our citizens. And all of that was done without any digital. Um, but around 2010, we started seeing different digital health interventions being, deployed in our state health hospitals. So some were due to Sri Lanka starting a master's program in biomedical informatics for medical practitioners, and the other one, there was the Indian Ocean tsunami, and after that there were some donations, non-governmental organizations coming in and helping out the Ministry of Health as well. On deploying these solutions, I think they also more or less mirrored our health system. So we have vertical programs for public health. We have hospitals under the line ministry, hospitals under the provincial health ministries. So likewise, we had data also in many silos. And patients were actually, when they interact with these digital health systems, they were not, being involved. I would say earlier they used to have a book, a clinic book when they come to the hospital. So all the notes were there and they could take it to the private sector for a second opinion or anything. But now with the electronic systems, all the data were in digital systems, and they were basically excluded, I would say, from having access to that information. Identifying all these weaknesses, we went on to develop the blueprint, a national digital health blueprint for Sri Lanka. And the idea was to adopt global health information exchange architectures, have globally accepted digital health standards, and have this ecosystem built in a modular way, so that health information can be shared between these different modules and have a clearer picture of the health system. So the digital health blueprint in Sri Lanka is a quite extensive document. And we also see it's not possible to achieve all of that in a very short time. So we would go in a sort of a phased-wise manner. So the initial part is to digitize whatever that's done manually, paper-based. So out of that 1,100 hospitals, we have about 120 hospitals which are digitized, and meaning OPDs, clinics, some ward activities, laboratories, radiology. Those are being digitized in those hospitals. And we have moved on to connecting and sharing that information as well. So we have a Lanka government cloud, a Lanka government network. Those infrastructure are being used to exchange this data across. So the connectivity is provided by them, and then we had a later intervention to start sharing this data as well. So this has been supported by many funding organizations, mainly the Debt to Health funding that came from the federal government of Germany and managed by the Global Fund, then World Bank funding, ADB, and also government of Sri Lanka. We are a bit different from some of the other countries because 99% of the funding comes from the government of Sri Lanka for the free healthcare that is being delivered in our country. When we started having this idea of having sharing this health information, one of the main objectives were to have this national electronic health record. So it's a patient-centric record where you can retrieve discrete pieces of information regarding a patient within the legally permitted limits. So we have, local legislation, though not directly applied to health, but then we have the Personal Data Protection Act, we have other legislations, ministry guidance, all of that, giving that the legal limits for data sharing. And we wanted this to be patient centric. The patient would have a high level of control on how their data is being shared with. But also, we want to support the research, monitoring, and evaluation of different health programs, and planning for the Ministry of Health. And also, the PDPA provides certain facilities where people would be able to ask for a erasure of their data. So that has also to be covered. And the diagram basically shows we have identified a minimal set of data that needs to be shared, and we have identified when they should be shared. So the triggers we have identified, and then by committing those into a sort of a longitudinal record, we want our citizens to have a birth to death health record created on behalf of them. So how did we go about doing it? So all of the work, of this, what we call the thin slice of the National Electronic Health Record, was to be funded by the Day to Health funding from Global Fund. But we knew that, from the blueprint to actual implementation, there's a huge gap. A lot of things needs to mature to get there. So one thing that we did locally is we created these national core FHIR profiles. About 25 FHIR resources were profiled. We created the FHIR implementation guide to commit data to the National Electronic Health Record, and we were supported by Gembi Health Systems to put up a test platform, and we held 4 connectons in the country. And as you see in the diagram, these colored components we managed to put up. So there's a OpenHIM as an interoperability layer. There's a mapping mediator, code systems, value sets are hosted in the OCL online. Then the GMPA was put up to be the client registry, and then also we had these FHIR installed as a FHIR repository to capture the data. All the EMR vendors, I would say 80% of the EMR vendors would that are operating in the state health sector came, and basically they modified their systems to commit the data to the National Electronic Health Record. So what is the motivation for the patient portal? Now we have a mechanism where all the EMRs basically can commit their data to a central FHIR repository, and the FHIR and the interoperability layer that's put in would allow us to have bidirectional data exchange with the EMR. So basically, some of the use cases like the patient portal ultimately might not be so valuable, but in the short term, we thought, and all the EMR vendors also thought, like, it'll be nice to have a single clinician portal which they can immediately or quickly embed into their EMRs, giving that visibility to that data in the National Electronic Health Record. But for the patient, we are hoping to have this patient portal to the National Electronic Health Record, which is currently a sort of a one-way, view-only mechanism. And we have wealth of information or evidence on literature that says it supports patient engagement. It improves the patient's knowledge and decision making. They get involved. They use preventive health services more because curative care is very expensive. Preventive is cost effective. So there's improved medication adherence, improved patient satisfaction. So there are so many benefits that we can achieve by implementing a patient portal. So we started working on it. So the first part is we started some workflows and identifying data elements, crude diagrams, low fidelity diagrams in the health information unit. So health information unit is the focal point for digital health within the Ministry of Health. Myself, before me, a lot of my colleagues worked on this, the patient portal aspect. And all of that information, we managed to use a local health tech company and an open source foundation in Sri Lanka to help us actually develop these high fidelity UI designs. And the whole, our aspiration was to link it with a backend, which was going to be, done in a programming language called Ballerina, and basically have this capability built into our National Electronic Health Record. But unfortunately, it did not go as planned. We had to stop it at the point of developing these high fidelity UIs. That's when Adrian and the team from Symbionix came into the picture. They reached out to us. And we discussed about the objectives and also how this can be a sort of a catalyst, not just in Sri Lanka but in the region as well, because most of the countries are looking for similar solutions, and whether we can develop something ultimately aiming to be a global digital good. So to take the story forward, I would like to invite Adrian Flo from Symbionix. Over to you, Adrian.
Oh, great. Thanks very much, Dr. Chaminda, and greetings, everyone. So I'm just going to start with saying that this patient and clinician portal is really a FHIR-based system. So its data source is designed to ingest FHIR, FHIR. So I'm not going to take a lot of time on this, but as you know, this is really a standard, a data standard, solving the problem of interoperability. And we're seeing this portal have an important role to play in this interoperability move towards interoperability. A lot of global investments are in that area increasingly. There's also very huge global adoption of FHIR, FHIR, HL7 FHIR as a standard. WHO is quite into this with their SMART guidelines, and many national and subnational mandates are there for FHIR as a standard. So, and Sri Lanka is one of them. So one of the important things about FHIR is that it provides a consolidated patient-level data model. I won't talk much more about FHIR, but it's quite critical that it is patient-centric and that it provides a consolidated view. So it's quite ideal to form a basis of a shared health record concept. So, okay, great. So, we're familiar with the problem of interoperability. How do you take, disparate systems that are using different data sets, being run by different organizations, and how do you make them speak to each other easily? So FHIR is solving that problem. So there's a move to attempt at building, FHIR data stores or health information exchanges, HIEs, to integrate these data silos, because the data silo problem is common, I think, to all of our countries. So I would say that infrastructure work is an important precursor to the patient portal, either whether there's a FHIR-based data repository or another kind of data repository with a FHIR API, or just an ability to move data, a data exchange that is FHIR compliant. Okay, those are the kind of things that are data sources for this portal. So a key thing that we're asking ourselves is, how do we leapfrog the data usage on these FHIR, all this FHIR work that's happening? Because I think, we all know that visible data use attracts investment, but not only that, data use is where we get the value out. So, and we think that the portal, providing a front end to this FHIR work is one way to achieve that. More people across the spectrum of technical and non-technical people can engage with the concepts, can envision what is possible, and can, and etc. So just to continue, all right. So what we see here is one infrastructure investment that can actually affect multiple diverse use cases. Because, I mean, we can talk about connecting, like, for example, a lab system to an EMR system, or et cetera, et cetera. All of those are quite involved to understand their workflows, and each of them would have their infrastructure costs. So what we're looking at here is having a portable health record that is actually more linked to the patient, or patient-centric, that can be moved around with the patient, that each of these different kind of use cases could actually leverage. Just briefly, we are developing this for the Sri Lanka National Electronic Health Record, but the idea is, and that's why we're presenting on this forum, is to contribute this to, others in the region who could benefit from a similar kind of infrastructure. We're solving a problem of, for example, the roaming patient, a patient going from facility to facility for whatever reason. They get care at one facility. When they go to the second facility, their historical health record is not available. So we're solving that problem. So if we can capture it in one place, great. We use FHIR to consolidate that data, and then we have a front end on that, and that front end can then be used wherever they go, wherever that patient roams to, and that obviously is going to be able to be used for all kinds of referral use cases. Telemedicine is also something we believe this will support. I won't talk too much on that. Two important financial implications that we think are important is reducing travel burden on low-income people. So, if they're able to engage with people, I mean, that's the whole thing of telemedicine, or one of the things, then, if they can get care, or they can coordinate their care, get appointments, whatever it is, they can do that through a patient portal, and in that way reduce the travel burden. And then, of course, if there's a continuity of care mechanism, then we can reduce the burden of repeated clinical procedures. So there's actually quite a good publication that I put there by Skippers and Stechbier from last year on the clinical value of IPS. I mean, IPS we don't necessarily only use IPS. We can really use any FHIR-based model. We can use IPS. But the concepts that are being presented in that paper really speak to a patient portal or a clinician portal, both of them, and what is the clinical value that it offers. So you can reference that. Okay, just briefly, the portal can be built on multiple kinds of, deployed in different kinds of ways. For example, it can be hospital-based. Let's say a hospital wants a patient portal to do service delivery on, with patients or appointments with that hospital or whatever it is. In other words, hospital-based. It can do that. It can be at a subnational level or national level, like what we're doing in Sri Lanka. It can be on HIEs, which would be your, as long as they are FHIR compliant. And, it also supports your international travel of patients across border. So, for example, the My Health at EU is a good reference point of a patient portal that is being used for cross-border use cases. So this is the kind of thing that we're trying to do, and you'll hear more about that in the architecture and etc. Again, to summarize, what we're really talking about here is that a patient usually doesn't have any access to their data. Sometimes in some countries or in some settings, they have limited access, maybe to a hospital has a portal and they can, access the data of that hospital, but nowhere else, or no lab information or whatever it is. Maybe a vertical program has a portal, and that's about it. Then for providers, we all know the scattered siloed system problem that can be inter-department level within a facility, inter-facility, national, because of all the different systems in use, and obviously international. So, it's really providing a solve on that. I want to lift out that I think we have an interesting concept that it brings about, which is the patient claiming their health record, which is an important thing about patient identity management, because we all know the complexities of patient identity management is a difficult problem in every country, whether there's a strong national ID, digital ID or not. In Sri Lanka, there isn't, but even in countries where there is, it's still a challenge. Linking health records to identities and patients like accessing their data like that. So there's an approach that we're proposing here, and I think that, or demonstrating here, and I think that's coming up. So really, all of this is just contributing to the universal health coverage concept or objective. It's improving access to health information, continuity of care, and empowering patient self-management. So I'm going to hand over to Martin from here to just take us into the architecture and demonstration of the system. Thanks, Martin. Over to you.
Perfect. Thank you, Adrian. Yeah, as just a continuation from what Adrian's also kind of mentioned. Also, why is this important? There's two key kind of personas that we've lifted out. There's a couple more as well, but for now, the two key personas is pretty much our patient and clinician. As a patient, they can own and share their own health data, being empowered to access their medical records from wherever they need to. It doesn't have to be at a hospital setting. It could be at the comfort of their home, because it's presented over the internet as a web application itself. Similar with the clinician, they're also able to see consolidated view of the patient, get access to that patient's information, and provide them better care. And once they come together, they actually become engaged with each other. There's that engagement factor of collaboration and communication. So this dives a little bit into the next slide that we have over here, which is a little bit more, the patient becomes empowered. They have access to their medical records. They can see their medical histories from not just a few weeks ago, but potentially even from a couple of years back that they might have forgotten. They also facilitate the patient linking process, so they can claim their medical records that they didn't previously have access to, especially in a setting where a patient might have multiple medical records spread across different health facility silos. And once the HIE consolidates them, the patient will be able to claim each of those profiles, provided they go through a verification process, which we'll be going through very shortly. And a couple of other areas which is very valuable for the patient in terms of potentially managing consent and building out kind of consent management policies per patient in terms of how they would like their data to be accessed and shared. All this allows that patient to be empowered. Moving on to the practitioner side, the practitioner becomes enabled. They are given a set of tools to allow them to facilitate better and more comprehensive care, and therefore also collaborate across the system with the patient. So they'll have access to a wider range of the HIE medical records. They can also get access to real-time updates, which facilitates collaborative care and therefore also drives better informed decision making. And once these two come together, it's the engagement factor, which allows the patient also to feel a lot more comforting. They're actually talking to somebody real time type of thing, and there's actual back and forth communications. There's a lot more engagement in terms of sharing of knowledge, guidance, and just setting a comfort setting, which is also very important, because medical can be sometimes very stressful. It's our health at play, and sometimes it can be very stressful to go through these settings. So having that comfort and reassurance becomes really important, and therefore the engagement. Cool. So moving a little bit on around the shaping of the definition and requirement from what we initially had. So this was building off of the initial concept designs that was developed and built, and kind of lifting out what was there and looking at an architecture that we can implement within Sri Lanka, but also in a broader context, that it can be reused. So I'll talk a little bit around the architecture itself. There's going to be a couple of slides around this, but this will also fall in place with the demonstration. So considering the HIE is already something that is existing, and clinicians are already making use of an EMR to potentially connect through the HIE to the NEHR, that existing building block already exists. We are bringing in the context of the patient portal, which can be considered as a building block that can sit on top of any HIE compliant instance, as long as we can communicate within a FHIR orientated server. So from a very high level, we have our NEHR, we have our EMRs, and then just the patient portal, which will integrate within the NEHR to gain access into the shared house record, and therefore getting access to the patient level data. Within the patient portal, we are splitting these services out, also just considering scalability aspects in future, so a separate backend, front end, etc. Even within the backends, those could also become quite modular in terms of the actual API endpoints and IAM access management. Those could in theory scale independently depending on each country's needs. Similar with our front ends, we also considering, well, not considering, we are implementing a kind of a component-based micro front end architecture that allows it to be a building block structure. By default, the portal will have all the building blocks available and good to go, or there's different approaches that can be taken to utilize and implement the portal. And I'll go through those pretty shortly. Okay, so still sticking with architecture level 1 context, so just following on kind of a C4 modeling aspect. So context is just a high level overview of what this integration would look like. So again, considering the NEHR is already something that existing, we could have various different EMRs, sources that connect to the NEHR, which will input the data and submit the data through to the NEHR. So this just basically indicates that it's not just a one system that will be able to connect. It's a multitude of systems that will be able to send and share data with the National Electronic Health Record, of which the patient portal would then also have access to that data and therefore be able to engage with that information. So this is also just indicating that the architecture will cater for multiple sources to engage and interact with the system, as well as multiple actors within each system. For example, you might have a doctor, a nurse, administrator, all within the same client itself. And each of these clients have their own users and use cases. Taking that another step further, in this scenario, we are currently integrating the patient portal with one HIE. So we're assuming that there is one data source. And in most cases, that would be sufficient. But there is the potential of what if there are multiple HIEs that you potentially want to integrate with. Our patient portal allows us to set up integration configs. By default, it needs one so that it knows where to fetch at least some integration data. But in theory, we could set it up to have a couple more. What I'll be showing now is the integration into a single instance, but we could also have 2 other or 3 other HIEs which we want to configure. Maybe you want to potentially pull data from a private medical services as long as it's FHIR compliant, or maybe there's an academic HIE that you also want to integrate with, which will facilitate pulling and pushing of data to those instances. Okay, moving on to our next level of our architecture. So this gets a little bit more detailed. This goes into the more container level aspects of things. I won't spend too much time on this. It does get a little bit more integrated and involved. It's just to highlight in terms of how we are architecting our component-based architecture. For example, within our patient portal, within the API, we will be able to build our authentication mechanism as a separate service, which can also scale independently depending on the high volumes it will be hitting. There'll be a lot more authentication requests in terms of getting data out. Also, a module for consent guards. If we have our consent mechanism in place, that could be a module that can scale separately and independently, and it can also be installed at other locations. The idea is that this consent guard could in theory be in front of the HIE, which could also then make sure that before data is exchanged outside of the portal, it confirms that, yeah, the correct consent for the patient has been applied. So we modularize it in such a way that these building blocks can be used outside of the portal itself. And I'll showcase now what that might look like. So as an example, our patient portal will have a fully functional front end, which will have the patient clinician admin front ends already built in. So it looks like one single website. But if you wanted to, you could have these independently deployed. So they can be deployed on their own domains, etc. And even inside of the front ends itself, we follow a component-based architecture, basically allowing components to be imported instead of an entire micro front end. And I'll show now what that looks like. Okay, so just coming into how would we go about implementing this. So let's say we are excited and keen, we want to get involved, but we're not sure how we're going to go about actually doing it. Currently, we have about three different ways that we can approach this. So we have the easy, intermediate, and hard approaches. It's just to kind of indicate the amount of work that might be needed for your internal development teams or engineering teams to get this up and running. The easy method is obviously it's a rapid deployment. The backend front end has all been built. It's been containerized. It just needs to be deployed. And then obviously configuration applied within the administrator. But the front end exists, the back end exists, everything has already been developed. No code is technically needed. It's just configuration. So very quick and easy. But if you do need some situations where you need a bit more flexibility, or you already have existing applications that you wanted to integrate with, you can follow the intermediate path. So this is a component-based architecture. So you already have your existing system. You can then just incorporate our health components, depending on which ones you would like to interact with and engage with. So you don't have to build a fully fledged website custom. You can just incorporate the components. Or if you do want full flexibility, as long as you have access to your API via secure token and secure mechanism, I'll also show now what that looks like. You are able to build out your fully fledged solution as long as it engages with our API under our policies and standards. But what the front end does, how you deal with the data in the front end, that is fully customizable. So depending on the different approaches you want, we can also cater for those. So build it yourself or use what's already there. Cool. So moving on to a key concept within our patient portals, identity management and identity linking. This is the process we are applying and implementing, which we kind of classifying as a trust triangle verification method. And there's three main key steps that need to happen within a trust triangle verification. Because of the sensitive nature of patient medical data, we can't just automatically grant a patient access once they've made the request. There needs to be a verification process in place. And for now, we are putting it that as a patient requests a claim on their medical record, they would need to present themselves at a health facility, which is patient portal registered, so that one of the clinicians that are allowed to search up that patient can verify that they are who they say they are. So it's an in-person verification that the clinician has to perform on the patient. So they need to present some kind of an identification, or there's a cross-checking checklist in terms of previous medical records, and they need to verify themselves. And once the clinician is happy with the verification process, they will approve it. They also get referenced under the approval for auditing process. So we always know which practitioner has approved a claim for a patient for historical auditing purposes. Only once the clinician approves the claim, an OTP is generated temporarily. Currently, we just keep it valid for 10 minutes, but this can be configuration based, which the patient then needs to go and populate into their patient claim within their portal. So they would need to log back into their patient portal, and for the initial claim that they presented, they can then go ahead and claim that profile. Cool. So what does this all look like in practice? So let me get this ready. So I'm just going to jump out of my slideshow and I'm going to go into a bit of a demonstration. Cool. So just as an example, before we get there, so these are the things I will be covering. So I'm just going to go a little bit through the admin, showing the integration config. I'm also going to be showing just a little bit around the trusted sources. This is when an external system wants to connect to our API. So when you are building your own implementation and you've been given an access token, you become a trusted source. And then a little bit from the practitioner being able to query the patient, view the history, and also approve a profile claim. And then from the patient side, being able to register, request a claim, confirm the claim, and also view their medical records that's been exposed via the HIE. So just a couple of links here that I'm going to go through. So there's the API at the back end. There's the front end aspect, which I'm going to be showing what's happening. The back end, there's nothing visible to see. I'll just show you that it does exist. The FHIR instance, this is just currently our data store that our portal is connecting to. And then just a sample simulated EMR, as if we have built this custom. We are not using the patient portal. We are using a customly built one. Okay, so just coming into the API itself, again, nothing to show here. It's just to indicate that this is where currently our API is up and running. Our hello world is just a ping endpoint. This is just to show that it's up and alive and running. This is our FHIR server. This is all just simulated test data. It is making use of a FHIR server. We've just preceded it with a couple of data points, but nothing too extensive. We have 67 patients, but some of these patients have quite a lot of encounters, which is going to feed through our display and visual aspect. I will get back to this one very shortly. This is our trusted EMR that's going to be integrating with our patient portal. So before I get to this point, I'm going to go to our actual NEHR platform. So what I'll first do is just log in as an administrator, just to kind of showcase the sections around there. Just to note, there's a lot that needs to be developed in terms of the UI aspects and also feature-rich functionalities. A lot of it is setting foundational aspects that can be built on top of. Okay, so starting off with our integration config. So we can see we've got our one integration config. If we wanted to, we can add more, but for now we're only using the one. And this is pointing to our patient portal Symbionix FHIR server. And it is connecting on all instances, whether it's an MPI or a shared auth record. Sometimes those can be split, and therefore it requires separate integration configurations, depending on whether you're looking up patient details or looking up the patient's medical details, and if they sit on different data stores. Okay, under trusted sources, this is where we'll come to create a new trusted source, like a facility or a new EMR that wants to connect. I've previously just created one for the Lady Ridge Hospital. There will be a lot more information that we capture along with this, but for now, once we create the trusted source, they get presented with a signing key. This is just a JWT signing key to ensure that the token is verified and signed. We use this to verify the token access on the API side. So the trusted source always needs to ensure that it is signed correctly, also with the verified issuer. The issuer relates to the trusted source. And we also need the practitioner's identifier as part of the JWT token, which we will verify within the FHIR server to ensure that it can't just be any practitioner trying to access information. So all these gatekeeping guards we still will be implementing as well to ensure access controls. Okay, so also just something basic, there is the user section, so I'm not going to go into too much details there. And then also just some general auditing logs. Every time a patient's information is accessed, we could see which patient accessed, which resource, etc., and what request. This is also just for auditing purposes to track who has access to whose information. Okay, so what I'm going to do now quickly is just go through a registration process quickly, just to show what that would look like. Okay, so I'm just going to start, create one for myself. Okay, so once the user signs up for the first time, we can either ask them if they already have an existing personal health number. So this is an identifier that's linked to an existing patient profile. So if they already have one and they know they have one, they can already start the claiming process. For now, just to showcase what this would look like if they don't, they can go and generate a new PHN, public health number, or sorry, personal health number, so that they can start capturing information. Okay, so I'm just going to go through this. This is just your general patient demographics. I'm not going to populate all of them. I'm just going to put some information in here. Okay, And once the registration process has been completed, we will also automatically generate NEHR patient portal PHN number for them, which will be a unique number for them across the patient portal generated identifiers. We will also allow them to obviously scan this. So at a facility, they could present this barcode to be easily scanned within the patient portal and therefore also pull up the information a lot quicker. But at this point, the user has been created. And if I go through to my dashboard, I can see I've got my one patient, which is Martin. So I've only really linked one patient at this point, but because I've created it, it's got no data. So currently there's no encounters, no diagnostic reports, etc. So this is the process of the patient wanting to go and claim a specific profile. So I now remembered, 5 years ago, I actually did have a medical record and I do remember my identifier. So I want to go and claim that record. So as a user, I will go under patient section, and this is where you can go and claim more of your records. So the user will come and say, okay, I want to claim a patient record. So I need to populate an identifier. I need to supply the identifier that I want to claim. So I'm just going to use an existing PHN. Okay, and I'm going to send through the request, and this will now send the request through and see, oh, that identifier did exist. So we're going to temporarily hold that patient link, but indicate that it exists. So we can see that there's a pending link. We don't surface this information to the front end. This is all actually redacted from the back end itself. This is just to give a very base indication that if your name doesn't start with a U or end with an R, actually maybe you've used an incorrect identifier, and therefore the approval process will be rejected at the facility. So that could also just be used for that. But at this point, if the user tries to navigate through to their dashboard, they are still only able to see the one record. The approval process hasn't been completed. Okay, so if we then go, let's just go back there. Okay, the patient would then need to present themselves at a facility, which is patient portal enabled so that the practitioner can verify them. So I'll move on to my simulated trusted source. So I'm now considering I'm in a simulated EMR. I've logged in. So this is just where I've now just generated my signing key. This is again just simulated as if the access token has been generated in the back end. Okay, and that's my practitioner ID. Okay, so if the practitioner or clinician then wants to come to the patient portal integration, they can see this red box over here. This is the component that's been implemented. So this is what we've actually implemented at a component level. The clinician can go and take that identifier that was supplied for that patient. So let me just get that again. And we can do a search on that identifier. So the patient will be presenting themselves at the facility. They will provide the identifier they used to claim the profile. And the user can then see, is that the right one? That was the wrong one. I apologize. That was that one. So they can search for this patient and get the information back. They can get a bit of details around this patient. So they can see there's one encounter on this patient. So they can even get a bit of information around the patient's information before the approval process. But on the right-hand side of here, under links, they can see that a request has come through. A patient portal has a pending claim, which the clinician now needs to verify. So the clinician will see, okay, so for Martin that's presented himself in front of me, they are trying to claim this record, which is Mr. Umar, and they go through that in-person verification. Once the clinician is happy that the person presented in front of them is the person trying to claim this link, they will go ahead and approve. So the clinician then says they agree, they approve to giving the user Martin access to this patient resource. Okay, once they do that, they get an OTP, which will be presented to the patient. This can either be presented verbally on a piece of paper or ideally via an email so that the patient has a reference to this once they get back home. Okay, so the OTP has now been given to the patient, so they will go back to their patient portal and they will want to claim it. So they go back to their patients and they say, I've received my OTP for this claim that I have, and they want to go and verify. So if we put in any OTP that doesn't exist, nothing will be verified. The record is still under pending state. If we supply the valid OTP, it will then go and say we've now completed our trust triangle verification process, and the user has now gained entry to this patient record. So I can see for this user, I've got 2 patients that exist there. So now you can go back to your dashboard and you can see that data has pulled through under your encounter. So under your view over here, you can see a combined view, which consolidates all of your linked patients. For example, if I click on Mr. Umar, you can see that. But if I go back to the previous one, there's nothing that's visibly shown there because there's no data captured against that patient. So maybe as a quick another example, just to kind of show what this looks like if there's more information. So let me just get another claim. So, claim, just put that one in. Okay, so again, similar process. The user has requested the claim. They need to present themselves at the health facility. The health facility would need to search them. They will find their record. They can see that there's a pending link that exists. They will go through the verification and claim process. They will feel comfortable and approve. Once they've approved, they will provide the OTP back to the patient. Okay, so let's just quickly verify this just to showcase what more information would look like. Okay, so now in this scenario, this user, Mr. Martin, has got 3 different patients linked within the HIE. All pulling potentially from different sources as well, hypothetically, depending on integration configs. But at this point in time, we can now see a lot more of that patient's medical information pulling through. So we can look specifically under this reference. There's only one encounter, or we can look under the other patient's details, which gives us a bit more information around that. And this is where we can start, as a patient, getting access to this information. Maybe one thing before kind of closing off was also just to showcase a little around the component-based architecture. So what I'm currently showing within the portal here is the actual portal itself. All the features already exist there. But what if you wanted to build your own? So what we have built out is a Symbionix FHIR Patient Portal components. This is still early days, but this is the foundation of being able to reuse these components. So as an example, we have a utility or component utility library. A lot of these are still coming soon. This is still very early days, but it just showcases in terms of how the patient portal could be utilized. For example, importing the library and then making use of the HTML element to gain entry. What I've also done is just as a showcase, this NPM package has been implemented on a showcase. Again, so just setting of a token. So just to show how this would work, if hypothetically you've already defined your access token, I'm just simulating this. And cool. And if once we refresh, we can then see now our token is valid. We can use those same previous requests that we were looking for. For example, the identifier, and get this information. So now we can see that same patient previously. We can also see the links, and we can also see the links at the bottom. So the Martin user on the patient portal has gotten that data linked. So this is also just an indication of using a component-based implementation depending on the approach that you want, making it a lot more modular in terms of how you want to implement it and what you would like to showcase. So depending on the different implementation approaches, we can cater for varying factors for those. Cool. So I think at this point, let me pause there for now, and then I will hand over back to Adrian.
Great. Thanks, Martin. I'm just going to wrap up really quickly. So I just want to talk about like the licensing. So our idea with this is to go with what's called the government-only business source license. Essentially, what that means is anyone, the source code would be publicly available. It's a source available license. Anyone would be able to do development on it. But in terms of production use, it would be restricted to ownership by national, provincial, local governments or public health authorities, or their service providers that, they have a formal agreement with. And then, this would basically be in the case until a change date, which would be the end of 2028, when then we would go on to a fully open source license that would not, which basically would mean, would remove that restriction, and that would be under the AGPL v3 license. I'm not going to take a lot of time here. We are in early days with this. We're quite excited about the prospects, about what this can offer. And we're hoping that this can offer more to the region. Like, we're very excited what's happening in Sri Lanka, and we're hoping that it could also add value to other countries and other partners, who want to collaborate on the development of it, etc. So, some of the things that we are thinking about prioritizing on the roadmap, telemedicine module, we think that's a key thing, that, or at least a linkage to another telemedicine system, if there is another one, because at the end of the day, this is the point at which the patient can initiate that process. Okay, I need help, for example. A communication module allowing Ministry of Health or whichever teams are working to send out warnings and alerts, targeted notices, etc. Having educational or self-care guides available, etc., etc., multilingual support, appointment management, etc., etc. So, like, a lot of interesting things that I think could be done, because essentially this is the interface that you have with your population or your population segment that you are dealing with. And I think that that's, etc. So, okay, good. Then, so basically, we are inviting the community to collaborate. So it's in early days. Like, you can see, we've made a list of things that we think are important things, but we are very keen to have collaboration. Let's say, for example, particular features that you think would be really valuable to the community that perhaps need to be bumped up the list and prioritized, etc. So in order to achieve that, we are welcoming collaboration according to the following. So we'd like to have an open session available, anyone can join, an architecture forum. So basically, Martin can unpack more on the existing architecture, but also get ideas and considerations from the community. And you can see how it would map to your existing systems architectures. Let me actually post this Google Form link. Thanks very much there, Alvin. So there we go. Okay. So you can actually indicate interest on the Google form that I put into the chat, either to receive, updates on the portal on development updates. Potentially, if you want to potentially attend the architecture forum on the 14th of May, that's next week, Wednesday. We'll also have a roadmap visioning forum. So it's basically opportunity. We want to hear from you, basically think together with your experienced minds as to what are the needs out there and how does this cross section with your existing plans, what would be prioritized, what would make this valuable, and also what we currently have, where like we want to be able to validate its value. So 21st of May, we'll be having an open forum for roadmap visioning. We are planning on doing a public source code release on the 30th of June. We just want to clean things up and get them, public ready. We are inviting an open to the public Slack channel for anyone to collaborate. And yeah, I think if you're interested in any of those, please feel free to fill in that Google form that I put in there. And thanks so much for listening and very engaging questions. I probably missed some questions, but thanks a lot. Over to you.
Yes, so thank you, Dr. Chaminda, Adrian, and Martin for the presentation and the demo. Also to our participants for making the time to join us tonight. Since we have already reached the top of the hour, and I think the questions in the chat box have already been answered. But before we officially close the session, maybe last words from our speakers and the AHIN Governing Committee, maybe Sir Jai and Dr. Alvin. Our speakers first.
So from Sri Lanka, this collaboration with the Sri Lanka College of Health Informatics and Symbionix taking this patient portal, we are hoping that it's not just something that is useful for Sri Lanka. It can be used by other countries as well. So open to collaborations. Thank you.
our Executive Director, Sir Jai.
Yeah, I'll just make a quick remark. I think congratulations to the Ministry of Health Sri Lanka team. It said like, right, the journey of 1,000 miles begins with the initial steps. I think you have already done that and walked much more. And then I can already see from the chat and the very engaging discussions, there are collaborations between the countries might also begin. Like I can see that in the chat already. Just had a one question, but it need not be answered today. It can be later, Chaminda and team. Just wanted to know how you selected those 4 institutions, what kind of institutions, whether it's tertiary, like referrals, teaching hospitals, what kind of like that can be answered later. That's it, and congratulations. Looking forward, like, we could take this learnings, and then like I think it's the beginning, maybe further experiences from this can also be shared. Thank you.
Yes, thank you, Sir Jai. To all our participants, we have already enabled the cameras. So if you would like to take a group photo with our speakers, please turn on your cameras. All right, thank you, everyone.